access to share my screen also. We've had snow on the ground here in North Carolina for almost a month. A couple weekends ago, we got like a foot of snow. And of course, when we get that much snow, the whole city shuts down for a good 2 weeks. So it's going to be 65 today. So we're hoping we get rid of all the snow.
Thank you.
All right. So let me get to my screen here. Whoops, don't want to do that. Can everybody see my screen?
We can.
Perfect. All right. So, this documentation excellence series, we're going to start with the elements of medical decision making. And then over the next couple webinars, next week and the week after, we're going to focus a lot on documentation. If you were here back in April, May of last year when I did a couple webinars, I don't talk a whole lot about coding because I think, and I'm sure most coders would agree, that providers, clinicians, we need to document our notes better. And so the focus that I on is the document. Anything that I'm concerned about, because if you remember from last year, I talk about documentation excellence. And when we document our notes, when we put our thoughts, what we're thinking about, how we're going to treat the patient, when we get that onto paper, we write excellent notes. A lot of times, all the algorithms and medical decision making that's going on in our brains doesn't quite make it to the patient's chart. And that's where we need to focus a little bit better on. Because if we strive to have excellent documentation, three things are going to happen. Our patient outcomes are going to improve. Our mitigation, we're going to mitigate our liability risk. And number three, as a byproduct of the first two, our coding is going to improve and it's going to be more accurate. So the patients win, we win, and our healthcare system wins. So that is my goal talking about coding and documentation. Yeah, 1999, most of I've also been a certified professional coder and a certified evaluation and management coder for about 12 years now. And I just wrote a book that I published on Amazon back in December. It's titled Mastering the Elements of Medical Decision Making. It is right here. It's a nice little book. I do have a coding excellence, and I write some articles for people. So I always want to talk about the impact of our coding on our healthcare system. It's so important that we realize that when we just check level 3 for everything, we're doing our healthcare system and us a disservice. So real quickly, just want to talk about the impact of our coding. Now, generally speaking, each clinician loses about $57,000 per year. So if you're in a How many full-time providers do you guys have approximately?
About 80.
80? Ooh, gosh. Okay. So potentially you could be losing up to $4 million a year. Advances in AI, with all the ambient AI programs that are out there. Microsoft Copilot has DAX. There's a couple other pretty prominent ones. We use DAX at my healthcare system, and it's wonderful. But stuff like this, we could definitely, especially if you're a standalone or private urgent care, they struggle big time in the summer when the volumes drop. They would love to have some extra money based on our improved and accurate coding. So there's some care evaluation and management benchmarks that believe from about 2 years ago. It's hard to find these numbers nowadays, but most of our new patients, generally about 51% are going to be level 3, and about 34% are level 4. Those are new patients. Our established patients, about 47% are level 3, and about 41% are level 4. So anywhere from 85 to 88% of the patients we see important for us to be able to differentiate between the two. Some have what's called a provider coding profile. What this does is it measures all the times you check level 2, level 3, level 4, and level 5, and then kind of calculates your average level of service. And the urgent care benchmark is about 3.4. It may be your profile for for new patients. Average ENM code is a 3.4, which is pretty good. The established patient, we can see this provider chose level 2 about 41% of the time, level 3 27%, and level 4 31%. So I think if a coding or compliance department sees this, they may look at this provider's level 2 visits and see if they're true level 2 or if they are level 3 visits. But you can see down here, the average established patient coding profile is a 2.9. So an average of 3.2 doesn't sound like a whole lot, but in this healthcare system, the difference between a 3.4 and a 3.2 is about $18 per encounter. Patients saw 4,750 patients for the year. So this is about an $85,000 loss for this provider. So it's very important for us to know the difference between a 3 and a 4. This is the American Medical Association's Elements of Medical Decision Making. This is the Bible, basically. There are 3 columns here. We have our number and complexity of problems addressed. What is the patient coming to our clinic for? Do they have any comorbid conditions? How do they look? Do they look pretty sick, or are they pretty stable, so to speak? That is the problems addressed column. The next column is the amount and complexity of data. This is going to be if we order any labs, point of care tests, if we review any external notes. And what is external to Yale? Is it anything outside of your urgent care centers?
Yes, that is correct, Brad.
Perfect. Okay. So if you're seeing a patient who was in the emergency department 3 days ago and now they come to your clinic, if you can visualize or see that emergency department note, that would be an external note. And we'll get a little bit more specific about that in just a minute. And then our last column over here is the risk of patient management. What are we doing for the patient? Are we telling the patient to take over-the-counter medicines? Are we writing prescription medication for them? Are we sending them to the emergency department? This falls under the risk of patient management. So again, we have 3 columns. If we look at the rows here, the top one here, this says that our level of medical decision-making is based on 2 out of 3 elements. So we have to hit 2 of 3 elements to get that level of service. In other words, if we have 2 moderates, or let's say we have 2 lows, so we have a low here and a low here, but then a high in the patient management, it's still only a low. Low is usually equivalent to a level 3, moderate is level 4, and high is level 5. We'll talk about each of these elements now. So we're going to look at that first column, the problems addressed. Now, for level 3, 2 or more self-limited or minor problems, 1 stable chronic illness, 1 stable acute illness, and that's gonna be, let's see here. Let's go over here. So let's go to our level 3, 1 acute uncomplicated illness or injury. The big difference, or the big gray area with coders and providers, is trying to differentiate an acute uncomplicated illness or injury from an acute illness with systemic symptoms. So let's talk about an acute uncomplicated illness. Now, these are some common symptoms or diagnoses that generally will fall into a level 3, okay? So a simple anterior nosebleed, urinary tract infections without complications, mild COVID with no comorbidities, conjunctivitis, simple strains and sprains, basically the simple stuff. These are patients where you walk in the room, their vital signs are normal, they generally do not have any comorbid conditions, and they look pretty good. They look pretty well. Okay, let's go over to a level 4. We're going to talk about a chronic illness with exacerbation. And this is huge in urgent care settings because we see a lot of patients who come in who have a history of asthma and they're having an exacerbation. These patients generally will fit into a level 4 in the problems addressed if they're having an asthma attack and we are treating it. Diabetics with an elevated blood glucose in the urgent care, this is going to be a chronic illness with exacerbation. And then hypertension, a patient with a history of hypertension who has an elevated blood pressure in the urgent care. Now, if we look at, let's look at the hypertension patient. So a patient comes in with severe back pain and their blood pressure is 160 over 100. And you look in their previous visits and their blood pressure has been good. It's been 130/80, but this time it's 160/100. But again, the patient has severe back pain. Now, we could think that the blood pressure is elevated because of the pain, and that's most likely the case. But let's take that same blood pressure, 160/100, in a patient with wrist pain for a month. And you look back in their chart, you don't see any blood pressures, but they come wrist pain for a month, pressure 160/100. This is likely not related to the wrist pain. And I would definitely recheck the blood pressure if it's still elevated to hypertension as a diagnosis and have a treatment plan for the hypertension. So again, those are one or more chronic illness with exacerbation. And this is basically if it's a mild to moderate exacerbation. If you look at the elements of medical decision-making back here, you'll see under the high, level 5, we have one or more chronic illness with a severe exacerbation. And I would think a severe exacerbation would be the asthma patient who comes in, they're tachypnic, they have audible wheezing, their pulse ox may be 90%. You give them a breathing treatment, they feel a little bit better, so you give them a second breathing treatment, and now they feel a lot better with the second treatment. Now there's no audible wheezing, their pulse ox is 96%, and their respiratory rate is back down to 16. That, in my opinion, would be a severe exacerbation when they're struggling with their breathing, their pulse ox is low, you give them a couple of breathing treatments, they start feeling a lot better. That would be more of a severe exacerbation to me. Do you guys do much like primary care, or is it strictly urgent care? Urgent care. So you probably won't see, you probably won't see a lot of patients coming in for their diabetes or their hypertension. This would only come into effect if, let's say, you have a patient who tests positive for COVID and they do have a history of diabetes and asthma. Even if it's stable, if anybody has a comorbidity that could increase the complexity of managing that patient, these can be added as diagnoses and a small treatment plan in your medical decision making. The best example of this would be a patient who is 70 years old and has a nasty wound on their foot, but they also have a history of diabetes. Even if their diabetes is stable, it still should be added as a diagnosis and a brief treatment plan, because diabetes can definitely change the way you manage this patient with a foot wound. I get a lot of questions about this one undiagnosed new problem with an uncertain prognosis. So this type of patient, I think the best example of this would be a patient with abdominal pain. Maybe they're having kind of general abdominal pain. In the clinic, you may check their urine. You may do a flat and upright or a KUB, or you may do a pregnancy test, or if you can do a blood count in your clinic, you may do a blood count. Well, if you do this and everything is negative, their urine's clean, pregnancy test is negative, x-ray looks good, and if you can do a blood count's fine. If they don't look sick enough that they need to go to the emergency department, this type of patient may fit into this undiagnosed new problem with uncertain prognosis. However, the guidelines state that these type of patients should have a high risk of morbidity without treatment. So some of the examples here, chest pain with no definitive diagnosis, your abdominal pain patient, syncope, dizziness, lump in breast, dehydration, fatigue is another one. These are all conditions where we may not have a definitive diagnosis, but again, there is a decent risk of morbidity if we're not in them for maybe an we're getting them referred to a specialist. And sometimes these patients will just need to go to the emergency department. Especially the chest pain, if the EKG looks fine. I mean, if they still are in that area where it could be an MI, we're definitely sending them to the emergency department. So kind of looking at an acute illness with systemic symptoms, if somebody meets SIRS criteria, so if they have a fever greater than 100.4, heart rate greater than 90, respiratory rate greater than 20, or leukocytosis or leukopenia, if they hit 2 of those 4 criteria, then they do have SIRS. So this is going to be your flu patient, flu patient with 102 or 103 fever and 120 heart rate. These patients meet SIRS criteria, and these patients, in my opinion, with good documentation, would be acute illnesses with systemic symptoms. And now some other symptoms that could be systemic are going to be fatigue, which affect your normal daily activities, a rash that is not dermatological in nature, so maybe a rash from syphilis or a rash from measles. Have you guys seen any measles up there? No?
Okay. There was one case in Kennecken, I think, at this point.
Okay. Nausea and vomiting, not in the setting of gastroenteritis, any confusion, dizziness, any joint or muscle pain, muscle aches. Those are systemic symptoms.
So I want to make sure our providers really hear that one, because that's a question that comes up a lot. What constitutes systemic? And fatigue is on there that really impacts patients. Not that I feel a little tired, but profound fatigue, right? So those patients that have mono. And on top of that, the folks that have pneumonia, that have nausea and fatigue and just feel like they got the wind knocked out of them, right? Really important to make sure they're documenting those things.
Exactly. And the major difference between a level 3 patient and a level 4 patient is going to be the morbidity. The guidelines state that an uncomplicated illness has a low risk of morbidity, and the guidelines for this acute illness with systemic symptoms states it has a high risk of morbidity. So anytime I check level 4 or level 5, I think the coders, and I'm doing it to help my documentation, but it's good to tell the coders, why is this patient with 103 fever, 120 heart rate, they tested positive for flu, why are they a level 4? Why are they higher risk than a patient who doesn't have a fever, doesn't have tachycardia, but tests positive for the flu? We need to document why we are concerned for that patient with a 103 fever and 120 heart rate. And it could be something simple as, patient looks ill, they do meet SIRS criteria. We're going to start them on Tamiflu or Intesolon and treat them outpatient with close follow-up. You can talk about your concern for meeting SIRS criteria or becoming septic. And if they have any comorbid conditions like asthma or CHF or diabetes, that definitely adds to it. We just need to document that morbidity with the patient. Because I know our coders, if we hit level 4 and we really don't document or explain that higher risk of morbidity, generally they're going to call it level 3. All right. So these are some examples of what I think meets an acute illness with systemic symptoms. Of course, we got our syncope, dizziness, vertigo. Some of those patients may even, of course, meet level 5. They may be strokes. So, but they would definitely at least be a level 4 in the problems addressed. Media with a it's interesting. The American Academy of Pediatrics came out with some guidelines a couple of years ago related to otitis media, and they basically said any patient who has a fever greater than 101 and they have strep or they have otitis media, they say that those are level 4 visits, because you've got an acute illness with systemic symptoms, the fever, plus prescribing amoxicillin for strep or for otitis. But if they don't have a fever, those are level 3 patients. Yes, question.
Dr. Shahid, you had a question?
Yeah, sorry, I was driving. A quick question. A lot of time when we have self-limiting, somebody have a URI and they don't have comorbidities, but they say, oh, I'm really tired and fatigued. Just like we see that all the time. But they don't have fever, everything is negative for COVID. What would you say? Can we still consider that a systemic symptom?
Appreciate it. No, this is one of the gray areas. I mean, and all their vitals are normal. If they look well, it's going to be, if it, again, I think it has to really affect their daily activities. I mean, and how that patient presents. Yep.
In the same breath, I've seen 5-6-year-old child with URI symptom. Oh, I'm
Again, that's going to be, what do the parents say, or how concerned are the parents about that kid's fatigue or their symptoms, and how do they look? I mean, we all know some kids that have strep where you walk in the room and they're like jumping all over the place, looking through all the drawers. They grab your stethoscope, they try to strangle you with your stethoscope. Those kids are fine. And then we've seen kids with strep where you walk in and they're just kind of sitting on mom's lap, and they're kind of like this because they got 102 fever, they look rough. These kids generally are level 4 patients with good documentation of your concern for their illness. Now, one thing, when we document that, I don't want you to document it like, oh my God, this child is so sick, just to get a level 4. I mean, don't please don't document your notes just to make it sound so good that they're level 4, because if something happens, if something bad happens, now you're in trouble legally. So one of my favorite lines is, a patient is looks ill but not toxic. looks ill but not toxic. Just don't document to make the patient look worse than he or she is, just to get a code. All right, so some of the other things here, of course, COVID with complications, UTI with complications, maybe they're having, an early pyelo, maybe they're having, left CVA tenderness, right CVA tenderness, nosebleed on anticoagulants, hives with respiratory symptoms. Generally, these patients meet acute illness with systemic symptoms. Question?
Yeah, I just had flashbacks of emergency room lectures with little kids, and the word lethargic or lethargy came to my mind.
Yes.
Because if they're really lethargic, they do belong in the emergency department rather than urgent care. But there's fatigue, and when I had COVID, I had both. I had fatigue and lethargy, but years ago when I had it. But it's. I want your comment about the word lethargy.
I don't like it. I mean, I do not like that word. If a team member, if I look at the chart and they put in there, patient feels lethargic. I mean, it's like, okay. I mean, you've almost.
Well, they look lethargic.
True, and I mean, you're almost guaranteed them a visit to the emergency department. It's like some emergency department providers I talk to, they complain if we send them a patient and saying, you're I try and tell my team members, please don't write that in the chart. I'm not a fan, but you're right. I mean, they are generally, level 5 if you send the are going to be particularly they're getting towards an infection, displaced fractures, long bone fractures, facial fractures, before pneumo or pulmonary contusion, clavicle fractures, especially medial third clavicular fracture, to some muscle injury. Of course, head injury with loss of consciousness, severe headache or vomiting. Basically, any head injury in a patient greater than 65 years old automatically should get a CAT scan of their head. And then in patient with multiple injuries, MVAs, patients who fall downstairs, those type of patients generally would need a complicated injury. And even in my opinion, ruptured bicep tendons that are pretty obvious, ruptured Achilles tendon that are pretty obvious. You do Thompson's test, you squeeze their calf and their foot does not move. If they're fully torn, those are complicated injuries. They need an urgent referral ortho because they're going to have surgery soon to fix that. Well, that's going to, I mean, if you and if we reduce a nursemaid's elbow, there's going to be a is that if we examine somebody and yep, they have a nursemaid's elbow, we reduce it. Now it depends on your documentation if we're billing an office visit with that CPT code. Okay. Generally, and I'll save that for later. But yeah, any dislocation, finger dislocation, nursemaids, those have procedure codes attached to them.
If someone comes in with a finger injury and then you find they have a dislocation, you're not sure it's fracture dislocation, but would you say their finger dislocation is acute uncomplicated or acute complicated?
Yeah, there's features in it. Generally, that's just a procedure code with no office visit. Just depends on the situation sometimes. But some patients who come in who they have a finger dislocation and they hurt their elbow, generally that would be an office visit plus a procedure code because the elbow pain is separate from the finger dislocation. And then we have to add a modifier 25 on there, and it gets a little complicated.
All right, thank you.
Yep, you're welcome. So, I mean, if the patient looks ill, document the patient looks ill. It seems kind of silly to say that, but it's true. Document all their complaints, and then we did talk about acute uncomplicated illness versus acute illness with systemic symptoms. That middle column, the complexity of data, this is pretty objective. I mean, the initial column problems addressed is a little bit more subjective, but this is pretty objective. So in order to get a level 3 complexity of data, there's 2 different categories. We have tests and documents. So if we order 2 point-of-care tests, we hit 2 points. So we would meet category 1, level 3. The easiest way to get level 3 is using an independent historian. And that's going to be mostly for our pediatric patients. You know, our 2-year-olds do not come in saying, yeah, you know, I've had a fever and a cough and some body aches for a couple of days. No, we're going to get that history from mom or dad, grandma or grandpa. If mom, you know, provides the history of present illness, we need to document that in our note. And it seems kind of silly that we'd have to document that for a 2-year-old or younger, but that's what the guidelines state. And I would say, you know, mom in the room and providing the HPI due to the patient's age. So make sure you're documenting if you're using an independent historian and why you're using an independent historian. Again, pediatrics is going to be the most common just because of the patient's age. Sometimes you'll see patients who have dementia and you have to rely on somebody with them for a proper HPI. Man flu does not work. I know when we get really sick, we can't talk as men because we're so sick. And our wives is not an independent historian, unfortunately. Level 4. So complexity of data for level 4 and level 5. So level 4 must meet the requirements of one of the 3 categories. Level 5 same 3, but then they added the independent historian here. So If we order 2 point-of-care tests, COVID and strep, and it's for a child, and we document an independent historian, we have 3 points. So we met category 1, which is level 4. And then if we write a prescription for amoxil for the kid with strep throat, we've hit a level 4 visit. So pediatric Lisinopril 20 milligrams a day and follow up at her office, if you document that discussion, you will meet category 3 of the complexity of data. And that would be, again, a level 4 in this column. And then, documenting complexity of data, if you order and review a test like COVID, it only counts 1 point, not 2. You don't get the order and the review, one or the other. Document if you reviewed an external note. Independent historian, we talked about independent interpretation of a test and discussion of management. Here's one too. If you discuss with the patient what labs you would like to order, but the patient refuses, you still get credit for this if it is documented. So if a patient comes in with fever and a cough and you want to do a COVID and a flu test, and they say, come on, Brad, this is my normal bronchitis. Just give me a Z-Pak and I'll be fine. If you document that discussion, discuss risk and benefits of COVID and influenza testing, but patient refuses, you still get credit for those 2 tests. Yes, question.
Brad, it's going back to the previous question. If you have a child and you give them OTC medication, let's say Delsym, so you prescribe them, is that going to be counted as a just OTC or prescription?
Excellent question. And the short answer is, if you prescribe, let's say you prescribe ibuprofen 800 milligrams, okay? Ibuprofen is available over the counter, of course, but only at 200 milligrams. So what if you prescribe, Delsym or ibuprofen, any of those medications that the patient can get over the counter? Generally, it will not count as prescription drug management. It would only count as over the counter. Now, in some cases, I've read where there's a Medicare reference for this, but if you document a risk of that prescription dose or a benefit of the prescription dose, it would count as prescription drug management. There's some good documentation to get that. I would not writing up an 800 milligrams. Oh, this is prescription management. I would just, 99% Delta will not count as prescription drug management. Risk of complications. Level 3 is basically telling the patient to take over-the-counter ibuprofen. Take over-the-counter ibuprofen for fever or pain. Wants to establish care with a primary care provider. If it's just a routine, in my mind, that's a low level 3 risk. But now if we've got somebody with a ruptured bicep tendon and we need them to see ortho like today or tomorrow and not 3 weeks from now, that's more of an urgent referral, which is level 4 in my mind, in my thinking. So these are some cases of level 3. Level 4, prescription medications. 1 or more nebulizers or oxygen or IV fluids in the clinic. Manipulate fractured This is something that we tend to miss a lot. Providers do. Now we can prescription drug management by writing a new prescription for the patient. Okay, Augmentin 875 milligrams twice a day for 10 days. That constitutes prescription drug management. When we start stop a medication. Say that patient comes in 2 days later who's been puking all over the place. Let's stop the Augmentin. That constitutes prescription drug management also. If we adjust the dosage of a medication, and maybe we won't do that a whole lot in urgent care, but if we have the patient comes in, their blood pressure is 180 over 100, they're taking 10 milligrams of lisinopril, and we want to increase it to 20 milligrams, that would count as prescription drug management, adjusting the dosage of that medication. And then if we continue a prescription medication and document it, that also counts as prescription drug management. So let's take the asthma exacerbation patient. First of all, if you're seeing a patient with an asthma exacerbation, 99% of the time, it's a level 4 visit because we have a chronic illness with exacerbation. As level 99.9% of the time. And then level 5, some of the stuff, drug therapy requiring monitoring. We're not going to hit much with that, but the unstable ED transfer, the patient having an acute MI, the patient having a stroke, the patient with a ruptured appendix or diverticulum, Those patients are very ill, and those are generally level 5 visits. So make sure you're documenting if you're telling the patient to take over-the-counter medications, the difference between a non-urgent and urgent referral. Prescription medication is when we start, continue, discontinue, or adjust a prescription medication. Prescription medication if the patient refuses. If we talk to the patient about Paxlovid and discuss the risk and benefits of Paxlovid, but the patient refuses, I think, again, in my thinking, I think that would constitute prescription drug management, as long as we document it. I ran a little bit over there. I get talking about this, I just get so excited. Any other questions for me?
Hey, can you talk about the difference between a acute uncomplicated illness or injury and acute stable illness?
Good question. State 5 days, they said, I'm feeling better, but this cough, I just can't get rid of this cough. That's going to be an acute stable illness. They're already being treated, they're improving, but not quite 100%. That's an acute stable illness. And then, of course, the acute complicated illness or the acute uncomplicated illness or injury have not yet been treated, basically. That make sense?
Yeah, so for a stable, it should be at least a second visit. Can it be a first visit, like they've been coughing for like a week and it's mostly better, but they just want us to listen to their lungs or something?
I mean, that could be the case. It also could be maybe they went to a different urgent care, another urgent care, and now 5 days later they're coming to you. They've been taking Augmentin and over-the-counter Delsym, and again, they feel better, but the cough is worse. Well, maybe you want to go up to Tessalon or a codeine cough syrup, or maybe you want to do an x-ray of their chest. Those, again, as long as they're improving, but not quite 100%, those are acute stable illnesses.
All right, thanks.
You're welcome.
Brad,
No.
same question. Would you say if the person has a URI and the cough is self-limiting, but he's here to see us, and we're just telling him to, what, it's going to get better in 5, 7 days, just continue.
For a few days and it's not improving, again, those are acute uncomplicated illnesses to me. Acute, the self-limited problems to me are, I've got 1 day of sinus congestion, or I bruised my finger, or something simple like that, a bug bite that's not all inflamed and abscess looking. Those are generally level 2 self-limiting problems. Good questions. I appreciate it. Any others?
Well, thank you, Brad. We appreciate you, and we'll see you again next week.
Thank you all. Take care.
Thank you.
Thank you very much.
You're welcome.
Thanks,
Have a
Brad.
good day.
Thank you.
Bye-bye.
Good. Bye-bye.